Clostridium is a genus of bacterium that are spore forming. Not all species will form spores, but many will. And they will be gram positive on staining. And the reason I say most of the time is because sometimes organisms like this, especially when they're stressed out, these are anaerobic organisms for the most part. And so when you stress them out and are doing things like a gram stain, they may not behave as appropriately as they should, but they do have that classic gram-positive organization. And like I said, they are, for the most part, obligate anaerobes, meaning oxygen is toxic to them and they will die. This genus is ubiquitous in the soil, water, sewage, meaning they can be associated with the GI tract. And the majority of species are harmless, but of course that's not fun for us to talk about in MedMicro. So we are going to talk about pathogenic species that can cause a variety of different manifestations of disease, including food poisoning, tetanus, botulism, and gas gangrene. There are, again, a number of different species in this genus. We're going to talk about only 4 of them. One thing I do want to mention very briefly is there has been kind of a change in the taxonomy. The genus is, if you say Clostridium, people will know what you mean. Sometimes people call it Clostridioides for this particular species. So either way, I'll accept it and people will know what you're talking about. But it's Clostridioides difficile, or C. diff. This is a spore-forming microorganism. It grows very rapidly but will die when exposed to oxygen. And for patients who are infected with this disease, for the most part, you're going to have diarrhea. But the bacterium produces what are called volatile fatty acids. And volatile fatty acids are also produced in the guts of cattle, which is why, cow poop smells the way cow poop does. So when a patient has diarrhea caused by Clostridium or C. diff, it'll have a barnyard type smell. I have never experienced that personally, either as a patient or in a clinical setting, but that's what they say. For the most part, with C. diff, the 2 manifestations of disease we're looking at are antibiotic-associated diarrhea, which is going to be diarrhea that begins after antibiotic therapy. Generally, what's happened is the antibiotics have wiped out the normal gut flora, and this has allowed Clostridium to bind to that empty area. For patients who can't clear the infection or maybe are otherwise compromised, we can also see a manifestation of disease called pseudomembranous colitis. This is a very severe form of disease. And if a colonoscopy is performed, you can actually see plaques that have formed inside the intestines. C. diff causes disease mostly through the production of toxins. It has an enterotoxin called toxin A. This recruits neutrophils to the area. And by doing that, it also disrupts the cell-to-cell junctions that allows the neutrophils to come in. And because of the disruption of the junctions, fluid can leak into the intestines, and that leads to diarrhea. It also has a cytotoxin, toxin B, that can depolymerize actin, and that destroys the cytoskeleton. And remember, especially in the intestines, those microvilli are super important for water absorption, and if the cytoskeleton is destroyed, that can prevent appropriate formation of microvilli. Strains without toxin A can still cause disease, so it is not necessary to cause disease to have toxin A. And there is a newly identified hypervirulent strain, lovely, isn't it? It produces a 3rd toxin called binary toxin, and it has upregulation of other toxins and is resistant to fluoroquinolones. So this one is particularly nasty. So one of the more recent papers I read had something like 20% of C. diff strains have this binary toxin. And so they have upregulation of the other 2 toxins and then this binary toxin, which not only upregulates these other two toxins, but has similar effects where the binary toxin can lead to more diarrhea and more cytoskeleton destruction. So that's a pretty nasty one to have. The bacterium is sometimes part of the normal microbiome in some people, but generally, if it's a very low level of the bacterium, your body can kind of keep it under control and not experience symptoms of disease. Generally, patients will develop the infection from exposure at a healthcare facility. And then when a patient has been prescribed antibiotics for whatever reason, whether prophylactic or because they have another type of infection, that allows the bacterium to take over. And what we're seeing here in this image on the right, these are the plaques that will form inside the intestines during the pseudomembranous colitis. And then here's a cross section where you can just see the bacteria all inside the intestinal lining, just really taking over. Infection is diagnosed through the presence of the bacterium, the toxins, and the symptoms. You can do nucleic acid testing of the strain to test for the presence of the toxins. So the genes that encode the toxins are very well known. So you can PCR amplify whether or not there's toxin production. Often discontinuing the antibiotic that originally was causing the symptoms can help. But again, when you have a patient that you've given antibiotics because they have one infection and then they develop this infection, do you want to stop that antibiotic therapy? So that's a question for healthcare providers to really have to think about. Many strains of C. diff are still sensitive to antibiotics. For example, metronidazole or vancomycin can help. However, you have to keep an eye on your patient because this bacterium forms spores. Sometimes spores can be left over from that first round of treatment, so you might have to do a second round of antibiotic treatment. So here's a C. diff colitis in a 60-year-old man who had a transplanted liver. So remember, anybody who's done organ transplants is likely going to have immune suppression because that keeps them from rejecting the new organ. 3 weeks before admission, he'd taken a 10-day course of TMP, SMT for sinusitis. On physical examination, he had a fever, moderate abdominal tenderness. Abdominal CT revealed thickening in the colon, but no abscess. Colonoscopy showed numerous plaques and kind of red mucosa consistent with pseudomembranous colitis. The patient was given oral metronidazole and intravenous levofloxacin. Stool immunoassay for C. diff toxin A was negative, but C. diff toxin was detected by both culture and cytotoxicity assay. So remember, just because it doesn't have toxin A doesn't mean it can't cause disease. Therapy was changed to oral vancomycin, and the patient responded with resolution of diarrhea and abdominal pain. This is an example of severe C. diff disease after antibiotic exposure in an immune-compromised patient with the classic presentation of pseudomembranous colitis. The diagnostic problems with immunoassays are well known and have been replaced by PCR that target the toxin genes. Treatment with metronidazole is currently preferred, although vancomycin is an acceptable alternative. We have lots of vancomycin resistance for other species of bacterium, so that's why metronidazole might be preferred. And again, the immunoassay for the toxin was negative. Perhaps a PCR would be positive, or perhaps this is a strain that just doesn't have toxin A. And finally, I believe we've talked about this before, one of the best therapies for C. diff infection is that repopulation, the fecal microbiome transplant. So again, I need you to think about why that would work to help treat a C. diff infection. And from the CDC, antibiotic-resistant C. diff is considered an urgent threat. Nearly 250,000 hospitalized patients in 2017, almost 13,000 deaths, $1 billion in healthcare costs. So it can cause life-threatening diarrhea. And it is the most common healthcare-associated infection. Our next Clostridium species is Clostridium perfringens. This is one that is often associated with gas gangrene or a soft tissue type of infection or gastroenteritis. And both of those things can be very negative. And what we see here is kind of that intermediate gram staining where sometimes it's gram positive, sometimes it's gram negative. And then of course, if we have it growing on blood agar, we see that it can be beta hemolytic. With soft tissue infections, you're looking at localized swelling and redness with gas formation in the soft tissues. And I don't mean to be gross, but it's med micro, it's always kind of gross. They say it's like, you can hear it like crackling, almost like if you're popping packing bubbles, I love those packing bubbles. You pop them, it's almost like a little type of therapy. That's kind of what it sounds like. There's also, it can cause muscle infections where you'll have the accumulation of pus in the muscle planes. This is where there's no muscle necrosis or systemic symptoms. Or you could have myonecrosis, which is the really dangerous one. You have destruction of the muscle tissue and systemic spread. Gastroenteritis, you can have two manifestations of disease, either food poisoning, which is going to be the rapid onset of cramps and diarrhea, no fever, nausea, vomiting, short duration, and self-limited. Very, very classic presentation of a foodborne illness. If you're very unlucky, there's necrotizing enteritis. It's acute necrotizing destruction of the jejunum with abdominal pain, vomiting, bloody diarrhea, and infection of the peritoneal cavity. This bacterium has a lot of toxins. There are major lethal toxins, alpha, beta, epsilon, and iota. There are, as far as we know, 5 different, they're considered types of C. perfringens. So the alpha toxin is in all types. It can lyse red blood cells, platelets, leukocytes, endothelial cells. So it's the one that's going to mediate a lot of that tissue destruction. Beta is one that causes intestinal stasis. So remember, in the gastrointestinal tract, the muscles are constantly kind of contracting to move food through for digestion. So you have a loss of that. A loss of mucosa, necrotic lesions, and this one can lead to necrotizing enteritis. Epsilon increases vascular permeability of the GI wall, which would lead to diarrhea. Iota is produced only by type E C. perfringens, and it can also cause necrotic activity and increased vascular permeability. The enterotoxin is mostly produced by type A, generally during the transition to the spore. Causes altered membrane permeability, which again leads to diarrhea, and can act as a super antigen, overstimulating the immune system. So type A C. perfringens will typically inhabit the GI tract, and it is widely found in nature, and it does form spores. Types B through E don't usually survive in the soil, but they do colonize GI tracts occasionally. And again, you have a variety of disease, mostly caused by type A. It really depends on where it gets. So in your patients that have the skin and soft tissue infections, cellulitis, fasciitis, muscle necrosis with gas formation in the soft tissue, extensive hemolysis and bleeding. Again, this is an anaerobic organism. It wants to be kind of deep within your tissues. Food poisoning is fairly common. Intoxication, so it's caused by toxin production with a short incubation, cramps and diarrhea, under 24 hours of clinical course, and reheating will destroy the enterotoxin. So if you heat your food well enough, you should not get Clostridium perfringens intoxication. However, because this is a microorganism that can sometimes form spores, if the spores get into the body, remember they can't be destroyed by heat. Spores are very, very resilient. You can have that necrotizing enteritis of the jejunum, which is mostly mediated by the beta toxin that's found in type C, Clostridium perfringens. Very high mortality. And for whatever reason, it's associated with pork and sweet potatoes. I don't really like pork, but I do love sweet potatoes. So Clostridium perfringens gastroenteritis associated with corned beef served at St. Patrick's Day celebrations. So St. Patrick's Day is coming up. Be careful with your corned beef. The Cleveland City Health Department received telephone calls from 15 people who became ill after eating corned beef purchased from a particular deli. After publicizing the outbreak, 156 people contacted the health department with a similar history. In addition to a history of diarrhea, 88% complained of abdominal cramping and 13 had vomiting, which developed an average of 12 hours after eating the meat. An investigation revealed that the deli had purchased 1,400 pounds of raw, salt-cured meat, and beginning on March 12th, the portions of the corned beef were boiled for 3 hours, allowed to cool at room temp, and then refrigerated. On March 16th and 17th, the meat was removed from the refrigerator, heated to 48.8, and served. Cultures of the meat yielded greater than 100,000 colonies. 10 to the 5th. Yeah, 100,000 colonies of Clostridium perfringens per gram. The health department recommended that if meat could not be served immediately after cooking, it should be rapidly cooled in ice and refrigerated. Before it is served, it should be warmed to at least 74 to destroy the heat-sensitive enterotoxin. So the issue is that they allowed the corned beef to cool so long that the bacterium can then grow. These are rapidly growing in culture, sometimes as fast as 8 to 10 minutes. This is one of the fastest bacteria. Very easy to culture as long as you use anaerobic conditions. You can do microscopy and see gram-negative rods. There are immune assays available. Especially for patients who have the skin and soft tissue infections, treatment usually will begin before diagnosis because of the rapid disease course. And often that will include debridement, so removal of all infected tissue, and high-dose penicillin therapy. With those skin and soft tissue infections and the necrotizing enterocolitis, you can have anywhere from 40 to 100% mortality. So this is a very dangerous infection for your patients.